Here's an echocardiogram of a female in her mid-40s. She has breast cancer, and she came because we wanted to know what her left ventricular function is. She needs chemotherapy. Her left ventricular function obviously is okay, but she has a completely different problem. She has pericardial disease, pericardial effusion to be exact. In this chapter, we'll find out more about pericardial disease. We'll talk about pericardial effusion, tamponade, constriction, and other forms of diseases that can affect the pericardium. Coming back to the introductory case you just saw, the patient with the pericardial effusion. How does it really impact the symptoms of this patient? What is the prognosis? How can we diagnose it? Well, to answer this question, we have to dig a bit deeper. We have to understand more about the physiology. We have to understand terms such as interventricular dependence, and also what the importance of intrathoracic and intrapericardial pressure is. Furthermore, we have to understand more about the pericardium itself.
Well, the pericardium consists of two layers. A thick, fairly fibrous layer, which is the so-called parietal pericardium, and a thinner, visceral part of the pericardium, which is attached to the epicardium. In between, there is a little gap, a gap which is filled with some fluid, usually not much more than 50 milliliters. Since the visceral pericardium is also very dense and thick, it is highly reflective, so we will easily see it with the help of echocardiography. This is not the case for the visceral pericardium. It is not quite clear why we actually have a pericardium. We can easily live without the pericardium, but we know that it limits the distension of the heart, that it facilitates the interaction and coupling of the ventricles and also the atria, and that it plays a role in facilitating twist and torsion, a function which is important for the ejection and for the relaxation of the heart. But now let us turn to the disease entity related to the pericardium, which we encounter most frequently, pericardial effusion. The pericardial fluid is secreted from the serous membranes of the pericardium, and usually we do not have much more than 50 milliliters within the interpericardial space. Pericardial fluid is used to lubricate the two layers so that they can glide on top of each other. If we have a pericardial effusion, we usually have some degree of mismatch between secretion and reabsorption, or there is some form of entry of pericardial fluid into the pericardial sac from the outside. Depending on what type of pericardial fluid accumulates within the pericardial sac, we can distinguish transitive, exudative, hemorrhagic, or malignant pericardial effusion. Transitive effusions are usually caused by congestive heart failure, myxedema, or nephrotic syndrome. The fluid is fairly clear. It has very little protein content, no cells, and usually also no leukocytes. Exudative pericardial effusions are usually caused by some form of infection, such as tuberculosis, or spread from empyema. The fluid itself has a high protein content and also many white blood cells. Hemorrhagic effusions are caused by trauma, rupture of aneurysms, or also in the setting of malignant disease. In addition, we can see it, for example, after heart operation if we have some form of hematoma. In malignant disease, we can also have hemorrhagic pericardial effusions. However, the fluid is not as hemorrhagic as you would have it if you have, for example, direct bleeding into the pericardial sac. We do, however, see a lot of cells which are typical for the primary tumor. There is a long list of specific causes for pericardial effusion. You will find this list also in your fact sheets, and also the specific characteristics of each of these individual causes. It is often quite difficult to determine what the true cause of a pericardial effusion is. Usually we would have to perform some form of extensive workup, which includes drainage of the fluid, analysis of the fluid, and sometimes even pericardial or myocardial biopsy, something which is not done if the patient only has a small pericardial effusion. But even in moderate to large pericardial effusions, we will see that we cannot clarify the cause for pericardial effusion. we have 26% acute and 12% chronic idiopathic pericardial effusions in this study. Other causes include malignant disease, iatrogenic, post-MI, uremic, and collagen disorders. In this study, there was a low percentage of infectious pericardial effusions. Of course, this is also a potential cause, and it certainly depends on the setting you work in, how frequently the individual causes of pericardial effusion occur. For example, in developing countries, we have a much higher frequency of tuberculosis as a cause of pericardial effusion as, for example, in Western countries. Certainly, echocardiography is not the only imaging modality with which we can detect a pericardial effusion. Sometimes we can see it with the help of X-ray, certainly in the case of a very large pericardial effusion, as you can see in this example. But we can also use CT, here's an example of the fluid right here, and MRI. With echocardiography, the diagnostic criteria for the diagnosis of a pericardial effusion is that of an echo-free space during diastole. It's important that we look for effusions in diastole and not in systole because, remember, we usually have some degree of pericardial fluid within the pericardial sac, and very frequently do we see a small gap during systole. Here's an example of an M-mode. You can see the echo-free space here, which corresponds to the pericardial effusion right down here. We have fluid between the parietal and the visceral layer of the pericardium. While M-mode was the primary tool used in the early days to detect the pericardial effusion, we now usually use 2D images in addition. Especially the pericardial views are very helpful, and also the apical views, and very important also the subcostal view. Here we can usually get a very good appreciation for the extent of the pericardial effusion. Remember, we said that a pericardial effusion is characterized by an echo-free space. However, there are also other causes of an echo-free or at least echo-poor space. Pericardial effusions, epicardial fat, a pericardial cyst, and ascites are differential diagnoses to a pericardial effusion. In clinical practice, it is often difficult to distinguish a pericardial from a pleural effusion, especially since both can happen or occur in the setting of cardiac disease. Here's an example of an echo-free space, which is fairly large, but this is not a pericardial effusion, but a pleural effusion. How can we distinguish it? Well, simply because it extends beyond the aorta, which is positioned here. You can see a small pericardial effusion as well. This effusion does not extend posterior to the aorta, and therefore we can say that this here must be the pericardial and this is the pleural effusion. Don't forget that we can also use atypical settings and atypical positions to visualize the echo-free space. Here is an example where we imaged the patient from the back. This must be a pleural effusion, especially because we also see lung tissue within the fluid. And here we are using a very high depth setting to visualize the extent of this fluid, which must be a pleural effusion.
Even though it's possible to image the lung even in the normal position that you image patients for echo by moving the transducer more towards the lung, it's probably advisable if you let the patient sit up and image them directly like the patient that I'm going to show you now. What you do is you just start somewhere at the bottom and just move the transducer upwards. And here you can nicely see the echo-free space and also the lung tissue. And if you go into a longitudinal position with the transducer, you can also estimate how large the pleural effusion actually is. Another way of going about this is just by going in a horizontal position and moving the transducer up from one intercostal space to the next. Okay, and then to see when the pleural effusion actually vanishes. So this is probably the top level of the pleural effusion on the right side. You can do the same thing on the other side. Again, start at the bottom. Again, we see here a pleural effusion and the lung tissue inside, and then move up until it vanishes. So this is probably where the pleural effusion ends. The same thing in a longitudinal view. The pleural effusion. So in our patient we have a pleural effusion both of the left and of the right side.
And here's another differential diagnosis, epicardial fat. We can see the fat as it wobbles attached to the epicardium right here. Usually we can see the epicardial fat much better if we also have a small pericardial effusion, which is visible here. Epicardial fat can sometimes appear quite echolucent, and it can be difficult to distinguish it from a true echo-free space. What I advise you to do is to simply increase the gain. What importance does epicardial fat have? Well, it is more frequent in patients who are obese, and in patients who have metabolic syndromes, and in patients who have diabetes and atrial fibrillation. There's also an association between coronary artery disease and the magnitude of epicardial fat. What are some other ways of distinguishing epicardial fat from pericardial effusion? Epicardial fat is usually absent posterior. Usually we have normal motion of the pericardium. As already mentioned, in epicardial fat we have low intensity echoes, and there's absence of fat above the right atrium in the four-chamber view. Now that we discussed what is not a pericardial effusion, let's go back to what is a pericardial effusion. First of all, we said that there is an echo-free space. However, this echo-free space does not necessarily have to be circumferential. It can also be localized. And to distinguish whether a pericardial effusion is localized or circumferential, we have to use multiple views. But here are some examples. Here is a short axis view which shows us the echo-free space right here below the inferior wall of the left ventricle. In other words, it is localized. So this example is what we see right down here, a localized pericardial effusion beneath the left ventricle. But it can also be localized more in the region of the right ventricle and the right atrium, or sometimes even in the region of the left atrium. And this is a four-chamber view which shows you a circumferential pericardial effusion. We have fluid surrounding the entire heart. Now in general, the larger pericardial effusion gets, the more or the higher the likelihood is that the pericardial effusion is actually circumferential. Remember, we talked about the fact that we can draw conclusions from the structure or from the appearance of the pericardial effusion as well. This is a transitive pericardial effusion. We have no structures within the pericardial sac. This must be a transitive pericardial effusion. Pericardial effusions which are transitive usually occur in the setting of, for example, nephrotic syndromes, viral infection, mixed edema, and congestive heart failure, very frequently also in the setting of right heart failure. In contrast, here's a patient who has a fibrinous pericardial effusion. The hallmark is that of fibrous strands, as you can see them here lateral to the left ventricle. If we focus more on this region, we can see how bizarre these fibrous strands can actually look. In addition, this patient also has pleural effusion. This is a patient who has staphylococcal pneumonia and pericarditis. Here's another example, this time of a patient who has tuberculosis. Again, you can see fibrous strands and a large pericardial effusion in this subcostal view. As already discussed, fibrous pericarditis is usually associated with some form of bacterial infection, either tuberculosis or Staph aureus infection, as you saw in these two cases previously. What is very important to consider is that patients who have fibrinous pericarditis have a higher risk of developing pericardial constriction. 30 to 50% of patients with tuberculosis actually do develop pericardial constriction. So you have to follow these patients. One other thing that you have to consider is that if you have some form of infection, bacterial but also viral, that there is a tendency of both the myocardium and the endocardium to also be involved on top of the pericardium, that you have some form of pancarditis. Here's an example of a patient who has a pericardial effusion and who also has endocarditis of the aortic valve. Now let's turn to hemorrhagic pericardial effusions. Just to review what the causes are: tuberculosis, malignant disorders, trauma, iatrogenic, in other words, cardiac surgery or interventional procedures, complications of myocardial infarction such as myocardial rupture, and aortic dissection if it is localized in the ascending aorta. Here's an example of a CT showing a hemorrhagic pericardial effusion right around the entire heart. What is the typical characteristic of a hemorrhagic pericardial effusion? Well, it depends on the concentration of blood within the pericardial sac. If it is truly blood, then we will see a fluid at the beginning, but later the blood tends to organize and forms a hematoma. If a hematoma forms, we will have a fairly echo-dense structure within the pericardial sac, and it might be quite difficult to really localize where this hematoma is. Is it truly within the pericardial sac, or is it mediastinal? In this situation, it is often very helpful to use other imaging modalities, as for example CT. In the echo report, you should always mention how large the pericardial effusion is. In other words, we should also quantify the size. Usually, a pericardial effusion is visible if it exceeds 15 to 35 milliliters. A small pericardial effusion is found if we have an echo-free space which is more than 10 millimeters, moderate between 10 to 20 millimeters, large more than 20 millimeters, and very large if it is more than 30 millimeters, and especially if it also shows some form of compression. However, in clinical practice, it is much more difficult to really quantify the size of a pericardial effusion. Measurements largely depend on where you measure, which view you're using, and if you really hit the pericardial effusion in the extension where it is largest. Therefore, I believe it is also good if you use some form of visual assessment. So let's take a look at a few loops. Here, on the left-hand side, you can see a very small pericardial effusion located more in the region of the right atrium, and maybe here, lateral to the left ventricle. This pericardial effusion here is a bit larger. It's circumferential. This is a moderately sized to large pericardial effusion. Here we can even see that there's inversion of the right atrial wall. And here is a pericardial effusion which is very large. We can even see that there is a swinging motion of the heart. This is a typical feature of a large pericardial effusion. Swinging heart. Don't forget to also quantify the size of the pericardial effusion using multiple views. Here's an example of the peristernal long axis view. An example of a very small pericardial effusion and a small to maybe moderately sized effusion. Almost 20 years ago, de Cruz also proposed a way of calculating the actual volume of pericardial fluid. This formula is based on the principle of calculating the volume of a prolat ellipsoid. Here you can see the formula. The way one goes about is that you image the patient best from a subcostal 4-chamber view. Then you trace the parietal pericardium and using the formula calculate the entire volume. Next, you trace the contour of the heart and again calculate the entire volume. And you subtract these two volumes from each other, and you're left over with the actual pericardial fluid. This formula actually works quite well, however there are some discrepancies. Nevertheless, I do find it quite helpful in special situations. Echocardiography has many purposes in the setting of pericardial effusion. Not only can we make the diagnosis, but we can also obtain information as to what the cause of effusion is. We can look at the hemodynamic importance of the effusion. We'll be discussing this in a later chapter. But it can also help us to steer pericardiocentesis. Pericardiocentesis is usually performed from a subcostal approach. With the help of echocardiography, we first look where the largest extension of the effusion is. Then we can steer the direction of the needle, and we can even inject contrast to be sure that we are really within the interpericardial space.
So as you just heard and saw in this presentation, there's much more to pericardial effusion than just an echo-free space. But we're not done yet. We still have to talk about the hemodynamic significance of a pericardial effusion.